thank you all again. My name is Erin Dowd. I'm Director of Government and Community Relations with Baptist Health. And I am honored to be here not only with our wonderful partners at the Chamber. Thank you to Daylin and to Paula, Brittany, and to all of our fellow Chamber members for allowing us to be with you today. But I'm excited that you're going to hear from one of our wonderful physicians at the Miami Neuroscience Institute, which is a part of the Baptist Health family. As you saw in the video, we take pride in our cutting edge and compassionate care, serving more than 1.5 million patients each year throughout our 11 hospitals, including the wonderful South Miami Hospital, led by Bill Duquette, a proud member of the ChamberSOUTH Board of Directors, our more than 100 outpatient facilities and physician practices, and our 4 centers of excellence, each of which seek to be preeminent in their respective fields, including the Miami Cardiac and Vascular Institute, the Miami Orthopedics and Sports Medicine Institute, the Miami Cancer Institute, and the Miami Neuroscience Institute. Our team at the Miami Neuroscience Institute includes experts in a wide range of specialties and provides South Florida with comprehensive and innovative techniques to diagnose and treat the brain, spine, and nervous system. Dr. Whiting, who you will hear from shortly, is part of our world-class Miami Neuroscience Institute's Spine Center. We're so proud that the Spine Center is anchored right here at our South Miami Hospital, with additional locations throughout South Florida to serve the greater community. At the Miami Neuroscience Institute Spine Center, we bring together physical medicine and rehabilitation specialists to diagnose and treat the source of your back, neck, or spine pain. Before I turn it back over to Daylin, we'd also like to remind you that starting this past Monday in Florida, all adults, actually individuals 16 and above, are now eligible to get the COVID vaccine. And the best way that you can help our tireless and wonderful healthcare heroes is to say yes to the COVID vaccine. So while our reasons may vary, our goal is the same: to end this pandemic so we can all be together again. Thank you so much again for having us today.
Thank you, Erin. Appreciate the words. I love the video. I'm a longtime Baptist patient for many different reasons, and really love the services and especially all of the outreach and the support that you provide our community. So thank you very much. It's now my pleasure to introduce Dr. Jobyna Whiting, who's a neurosurgeon, as Erin said, with Baptist Health Neuroscience Center and a member of Baptist Health Medical Group, an organization of more than 180 physicians in multiple specialties closely aligned with Baptist Health South Florida. She specializes in endovascular neurosurgery, complex spine surgery, and general neurosurgery. Dr. Whiting received her undergraduate degree from Bowdoin College in Brunswick, Maine. She obtained her medical degree from the University of Pittsburgh School of Medicine and completed an internship in general surgery at the University of Florida, followed by a residency in neurosurgery. During her residency, she received numerous honors, including the Charles Chuck Schenck Award in Neurosurgical Excellence and the Sherry Apple Resident Travel Award for an outstanding resident abstract at the Congress of Neurosurgical Surgeons annual meeting. In addition, Dr. Whiting completed a fellowship in endovascular surgery at the University of Florida. She is also, prior to joining Baptist, she was in private practice in Orlando. Board eligible, Dr. Whiting previously was an assistant professor of clinical neurosurgery at Columbia University. She's a member of the Congress of Neurological Surgeons and the American Association of Neurological Surgeons. She has lectured and presented research findings at medical meetings and published in medical journals. And it really is a pleasure to have you here with us today, telling us a little bit about what you do. What an impressive bio.
Well, thank you very much, and I appreciate this opportunity, and I'm really looking forward to it. I am going to, I guess, share my screen to get started. Oh, hold on. Sorry, I'm not great at this. There we go. Okay, is that working?
Okay, try it again. Press the share screen button that's on the bottom.
Oh, yes, I think.
There you go. Perfect. Perfect.
Okay. All right. Thank you. We'll make it work. Thank you for that introduction. I really appreciate it. And thank you for this opportunity and invitation. It's my pleasure. I love being able to interact with the community and try to help people understand a little bit better what we're doing here at the Miami Neuroscience Institute and specifically at the Spine Center. Let me get started. As noted, my name is Jobyna Whiting, and I am the director of the Adult Degenerative Spine Program here at the Miami Neuro Institute at Baptist Health, South Florida. We have offices that are centered, as was noted, at South Miami Hospital, and then we also have some offices at other campuses as well. So to start, I'm just going to give a brief overlay of the human spine anatomy. Most of us know some version of this. In a nutshell, the human spine is made up of bones called vertebra, and there are associated little shock-absorbing soft tissue masses called discs that are in between the vertebra, and they kind of serve as shock absorbers. And then there's some ligaments and tendons that hold everything together. There are 7 cervical vertebrae, and that's what we call the neck. There are 12 thoracic vertebrae that form the mid-back, and those 12 thoracic vertebrae are anchoring spots for our ribs. And then below that, there are 5 lumbar vertebrae, which we usually refer to as our low back. And the spine ends in the sacrum and the coccyx, which is the terminus of the spine, and often referred to sort of colloquially as a tailbone. The spine's function is multiple. It serves stability and structure for the body. It also acts as a protective covering for the spinal cord and the nerves that run throughout the entirety of the spine. And it provides an anatomic pathway from the brain to the rest of the body. So basically, this is what allows the brain to talk to the spinal cord so that it can talk to the nerves and talk to all the rest of the body and control what's happening throughout your body for almost really every single aspect of function. So it's pretty important. You're only as old as your spine. Is something that Joseph Pilati, who developed some excellent spine and core strengthening exercises, once said. And so I, at least, if I'm thinking about it, like to imagine my spine about as old as this. But then I try to get up off the couch after watching a show with my husband, and I feel something more like this. And so the question is, how do we wind up going from here and then one day waking up and feeling like every time we move, we're looking something more along the lines of this. And it's a common issue that happens to everybody. Our spine ages as we go along. The short answer to that, or maybe even the long answer to that question of spine health and aging is called degenerative disc disease. And basically, this is a term that's used in the medical profession and the medical literature to describe the deterioration of one or more of the intervertebral disc spaces of the spine. In layman's terms, this is a term that we as physicians use to describe wear and tear or the aging process on our spine, and particularly on the motion segments or those segments of disc shock absorber in between the bones. It is extremely common, and of course, it increases in incidence as we age. When we're talking about it, the frequency is roughly described in proportion to a person's age. So we'd say that about 40% of people in their 40s have some sort of visible, at least sometimes intermittently symptomatic degenerative disc disease. But by the time you're in your 80s, about 80% of the population is going to be suffering from some sort of example of degenerative disc disease related symptoms. The presentation and the symptoms vary, and it's wide, it's diffuse, and it's sometimes vague. But a common theme is that there's usually some version of radiculopathy. And when I say radiculopathy, really I just mean dysfunction or problems of a nerve root. The nerve root is where the nerve is leaving the spinal cord so that it can go out to the body and do its job. The most common way that this presents is sensory. So some sort of sensation issue, whether that's pain, which is what usually brings people to see someone like me or some other doctor. It's the most noticeable symptom, and it's the symptom that's most bothersome to people's lives. A lot of people think of it as sciatica, but as a physician, I would probably describe it more accurately as radiculopathy. Other ways that it can present with sensory are numbness and tingling, but that usually doesn't bring people into my office quite as quickly as pain does. Nerves do sensation, but they also serve a function for motor, and they move your arms and your muscles. So the motor part of the nerve can also dysfunction as part of radiculopathy and as part of degeneration. That's less common, which is kind of lucky, but it's generally thought to be more serious because it limits your function, and if permanent, can really cause a long-term problem with your lifestyle and your functioning. An example of that, which could be attributed to degenerative disc disease and a single nerve root, would be a foot drop. And it's possible that some of you have either experienced something like this or know someone who has, and that can be pretty bothersome, and that will almost always get somebody into the door of a medical professional pretty quickly. So when we talk about radiculopathy, as I noted before, this is pain or some other symptom in the distribution of a nerve root. And this is the nerve root coming off of the spinal cord here. So the spinal cord carries all the information from the brain, and then at predetermined levels, depending on where it's supposed to go, it forms a nerve root, and then that nerve root travels out into the body and forms other smaller nerves that go to the arm, that go to the leg, that go to different muscles and each extremity, things like that. The pain part of radiculopathy will radiate down an arm or a leg, and it's in a specific pattern that's very helpful to someone like me in identifying where it's coming from, because nerves follow rules. So the muscles or the distribution of a nerve root are basically going to be the same time after time. So if I ask you as a patient, can you show me where on your arm it hurts or where on your leg it hurts? The reason why I'm doing that is not because I'm really worried about the leg or the arm, but because I want to know the distribution of the nerve root, because that will help me know which level of the spine might be having a problem with degeneration. When people come to me and complain about radicular pain, they don't come in and say, hey, I'm having radicular pain today. They usually say they have a burning or an aching running down their arm or their leg. Sometimes they would even say nerve pain. It's hard to know what you mean by that, but everybody sort of has a vague feeling of it, and it's usually pretty accurate. This type of pain can be debilitating. Even though it's really common, it is also often really severe. Chronic pain, if it's not dealt with, really decreases the overall quality of life. People often have to make major changes to their lifestyle or their activities to reduce the pain. So they feel like maybe they're doing okay, but now they can't participate in even half of the normal activities that they would enjoy or usually do. Sometimes this type of pain can threaten your ability to work effectively, either because of the pain itself or because of an actual physical limitation. So this can be a very serious situation in the big picture of things. So cervical or neck and lumbar or low back are the most common sites of radicular symptoms. If it's cervical, you're gonna notice pain that's coming from your neck, and not just staying in your neck, but traveling out into your shoulder or your arm, and then sometimes going into one or more of the fingers. If it's in your leg, this is what people will typically refer to as sciatica. And the reason for that is because there's a big nerve that runs down the back of the leg, and that's called the sciatic nerve. The radicular part of that is that that sciatic nerve is made up of multiple nerve roots. When we're talking about degenerative disc disease, it's usually just one or maybe two of those nerve roots that's involved. But what you'll notice is pain running down the leg. So it's very common to call that sciatica. When we think about degenerative disc disease as an overall issue, it's extremely, extremely common. So as many as 85% of the population will have some sort of radicular symptoms during their lifetime. It's really common to think of yourself as having some sciatica that flares up from time to time. For most people, the episodes are self-limited. You change what you're doing for a day or two, you take some ibuprofen, you rest, and it goes away. Treatment arms for persistent pain that either recurs and recurs and recurs or that will not go away are divided into two sides, and there's conservative treatment and there's surgical treatment. Conservative is what we use essentially as a term to describe all of the treatment that's not surgical. It's a huge variety of things. And there are many, many different options to try for conservative, and these can be tailored to individual patients. Ultimately, only about 10 to 20% of patients who have radicular symptoms wind up needing surgery. So the diagnosis of degenerative disc disease typically starts with your primary care provider. And I guess the question is, when do you go to see your primary care provider? We all have aches and pains. We all have aches and pains in our neck, in our back. It's a common thing. And if we ran to our doctor every single time we got a twinge, we wouldn't have time to do much more. But there are some pretty reliable things to notice for yourself that should be a little bit of a hint that it's time to call your doctor. If you're having radicular or sciatic style pain that's lasting more than 1 to 2 weeks persistently, it's probably a good idea to get it looked at. That doesn't mean it's going to be serious. That doesn't mean it's going to need surgery, but it does probably mean that it's a good idea to get a medical professional to at least take a look. If you have really severe sciatica style pain that's not responding to NSAIDs, and by that I mean ibuprofen or Aleve or something like that, or to Tylenol. If you have what I would describe as neuro changes, like if you have new weakness or significant numbness in your fingers, in your arm, in your leg, that's new for you, I think that is a very good reason to call your doctor and see if maybe something else is going on. There are some things that are very important to pay attention to. And so if you're having this type of pain and then you have an episode of urinary or bowel dysfunction, you should just go get help immediately. Again, there are many reasons to have those types of symptoms. They don't all have to be associated with nerves being in trouble, but it's not the type of thing that you want to take chances with. So we typically recommend that people get help for that right away. Your primary care physician is usually going to start early conservative treatment. They're going to ask you to do some sort of anti-inflammatory therapy if that's safe for you, such as, again, ibuprofen or Aleve, or occasionally even a short dose of oral steroids. They might give you a prescription for physical therapy, which is typically done in the outpatient setting. And they may have some conversations with you about weight loss, which can have a really, really heavy impact on your spine health. However, if there are worrisome factors that the physician feels indicate something more serious is going on, or if you try these things and the pain just won't go away, then it's likely that they're going to move towards imaging. Now, imaging has changed significantly over the years. In the ancient Arabic world, in one of their top medical texts, this was considered a very forward-thinking and accurate depiction of the spine and the rest of the human skeletal system. And for the time, I will say it was pretty accurate, but when we look at it today, it kind of looks more like this to us because it's so rudimentary. So luckily, we have made some very, very big advances in images. And now, literally almost anywhere in the country, you can get this kind of technology. And certainly here at Baptist, we're lucky enough to have very good 3D reconstructions of CTs, which is what this is, where you not only see the spine in very good detail, but you see its attachment to other parts of the body, like the pelvis and the ribs, and they can even superimpose some of the organs like the liver and the kidneys and the spleen. And this is all readily available now, which has made a big difference in our ability to diagnose things. Now, it's unlikely that you're going to get sent straight from your doctor's office for a 3D CT, but you may get an X-ray. X-rays are, of course, the traditional type of imaging that we've always had, and they used to be very, very important in diagnosis, but they have been largely replaced now with a CT and an MRI. They are still useful in certain situations, and they're very common to be the first thing that gets ordered, but it is pretty rare for this to give the diagnostic answer, and very frequently you'll need something more. And that's not necessarily a bad thing. If you get an X-ray and they say, hey, we see a little osteoarthritis here, we want you to get a CT or we want you to get an MRI, that is not necessarily bad news, and it doesn't necessarily mean something bad is happening. It just means that we now have imaging that can give us better details for the doctors to take a look. A CT can be very helpful. There are pros to getting a CT or a CAT scan. It is very good for bony detail. So what we're seeing here is a very, very clear and defined picture of the vertebral bodies. Also the spinous processes, which come out, and those are the little bumps that you can feel down the middle of the back of your spine. It's very quick to get this. A scan takes maybe 5 minutes. They are widely available, even in small towns. It's easy for us here in larger cities where we have really developed and great medical systems like Baptist, but there are places, even in our own country, where the resources are a little bit smaller, but it's easy even there to get CAT scans. They're excellent for emergency situations because they will show a broken bone very easily and because they're quick to get. There are some cons to the CT as well. You can see here, we can see these bones great, but it's just a gray spot where the disc is supposed to be. This is where your spinal cord comes and ends up here, and then there should be nerve roots here. And they're there, we just can't see them on the CAT scan. That's not what this is good at looking at. You also have some radiation that you're exposed to with a CAT scan, so you don't want to do that unless you're getting some good information out of it. And when you compare it to an X-ray anyway, it's significantly more expensive. The MRI is really the gold standard for diagnosis of degenerative disc disease. It's kind of in the name, degenerative disc disease. Here's the disc. We can see them so much more clearly on MRI. Here's where that spinal cord ended, like I was mentioning. These gray lines are the spinal nerves that are coming down from the bottom of the spinal cord here. And this particular picture shows why this is so good for degenerative disc disease, because this is a big disc herniation that is coming out of this L5-S1 disc space. It's coming up and it's pressing on a nerve root. And so that's something that we can see very clearly with an MRI. It also doesn't have any radiation, which is nice. Again, these are expensive. They're not quite as widely available as CAT scans are. And you sometimes have to travel a little bit to get to an MRI, especially if you're outside of a large city. They are very small because of the strength of magnet that needs to be used and the size of it. And so it can be difficult for claustrophobic patients, and it takes longer than a CAT scan or an X-ray. Nonetheless, it's very, very useful for diagnosis. When we start thinking about treating degenerative disc disease after we've diagnosed it, again, we're back to that sort of conservative or non-surgical versus surgical paradigm. And all of us, surgeons included, tend to feel that non-surgical treatment should be considered first unless there's some sort of very strong reason not to. It is less invasive and less dangerous. It is less expensive, and it is very frequently successful. In addition, almost everyone would rather get rid of their symptoms without surgery if that's at all possible. So this is something we try to make sure that we do whatever possible before considering surgery. There are a wide variety of options available for conservative treatment, medications, physical therapy, specialized exercise programs, specifically for the type of injury that you may have, weight loss, as we talked about, injections, or other much more minor interventions that are not as invasive or risky as surgery. Conservative spine therapy has been around since ancient times, and while these look like torture contraptions, they're actually traction options for patients as far back as the Middle Ages. And again, it really hasn't changed that much in terms of still sometimes looking like a torture device, but this is a traction table that's pretty sophisticated and can provide lots of different decompressive options for the spine. The treatment of degenerative disc disease without surgery is so common and so prevalent that we have a whole huge team of physiatrists and rehabilitation and pain management specialists. And these people are my partners. They're physicians, and they make up the non-surgical arm of our spine center. And they are centered again at South Miami, but also at multiple other sites. Our spine center brings together a variety of different arms of treatment, from physical medicine to rehabilitation specialists. They help diagnose the problems and they help treat the problems. Their main goal is to get rid of your pain and try to get you back to a more functional life. But they work extremely closely with myself and my surgical partners so that they are aware when it's time for surgical evaluation, when it's time to move beyond conservative care and talk to a surgeon about whether or not surgery might be helpful. They just cycle the patients over to us so that we can try to provide a full service in one system. The spine center conservative options, they have many sites. They have a spot at Baptist Hospital, as well as being centered out of South Miami Hospital, which is a very nice facility. And then they have several outpatient sites to try to make things more convenient for our community in terms of getting the patient seen without making them travel too far from home. When conservative efforts don't work, then someone like me has to get involved, and we have to talk about the potential for surgical treatment. I'd say that roughly 10 to 15% of patients who get degenerative disc disease will ultimately need surgical treatment and be appropriate for it. Again, this is sort of a common theme that I'm bringing up time and again because it is important, and that's that surgery is usually not considered until after thorough conservative therapy has been tried and failed. Surgery is an excellent option for a select group of patients who are suffering from degenerative disc disease, but it has to be used with discretion. Of course, I think surgery is great. It's what I do for a living, but it's really important to be used cautiously and appropriately so that we're only doing it in the appropriate settings. There are many surgical options for the spine, and it can become really confusing, especially if you talk to somebody else who had surgery and then you're wondering what kind of surgery your surgeon is talking to you about. Even for a similar diagnosis, every person is different. And so your particular surgical option is going to depend on you and your spine and your findings and your symptoms. And it should be individualized to you as a patient by your surgeon. The overall philosophy is to do the smallest amount of surgery that will take care of the patient. And that is a philosophy that I definitely live and work by. Certainly, sometimes we have to do big surgeries, and there's nothing wrong with that. But definitely what I attempt is to find the smallest, safest surgery that gets the job done appropriately and gives the patient the relief and care that they need. So a typical scenario for me, for somebody who might need surgery for degenerative disc disease, is that this is a patient who, in spite of trying conservative efforts is having either persistent pain or numbness. Typically, it's persistent pain that brings people to me to actually consider surgery. That doesn't mean it's wrong to consider surgery for persistent numbness. I just find that the pain is what bothers people more, usually. You'll have imaging, typically an MRI, maybe a CAT scan, that shows degenerative disc disease and that shows a problem that matches the distribution or the place where your symptoms are happening. You will have already failed extensive conservative efforts, including many of the things we already talked about, physical therapy, medications, maybe some minor interventions. And usually the way that this happens is you'll get sent to my office, either from the spine center, from the non-surgical partners that I have, or maybe from your primary medical doctor. And that's typically how the pathway works. And then you and I will meet and we will talk about what's happening with you and whether there might be a surgical option, and we'll plan all that out. Now, it doesn't always happen that way, and there can be more urgent situations. Usually, if I'm seeing a patient who might need surgery more urgently, then they've come through the emergency room. Not always, but usually. Reasons for this might be severe unrelenting pain that they just can't handle at home. They may even have to be hospitalized for pain control. They may have been having this pain for the past few weeks and be needing to use prolonged opioids. Use of opioids beyond a few days or weeks at the most can become extremely problematic in and of itself. And that can be a reason to consider surgery for pain relief if you can't handle the pain without a narcotic. Being unable to attend to normal activities of daily living, not being able to get out of bed, not being able to shower yourself, not being able to dress yourself, not being able to transport yourself to and from places or to go to work. These are reasons that you might come see me without going through all of the other non-surgical options that we typically do because you just can't. Your problem is too pressing. You might have a significant neurodeficit, and usually what we mean by that is weakness, like maybe a foot drop or maybe an inability to close your hand and hold things. That's not something you want to wait 2 or 3 months and see if physical therapy can fix necessarily. You may want to be evaluated by a surgeon more quickly. There's something that we call a red flag, and for spine health, red flags usually are something like bladder, bowel, or sexual dysfunction that is new and sudden. And that can be a very bad sign and something that needs to be looked at immediately. Profound sudden weakness or genital numbness. Now, these are things that your doctor knows about. And if they hear something like that, they're going to send you either directly to the emergency room or straight to me. If you notice any of these things, I would just go to the emergency room. It's rare. Typically, the way that this type of thing, that degenerative disc disease presents, is what we've been talking about before, with a persistent pain in a sciatic style distribution, or numbness, or some mild weakness. So there are multiple different types of surgical treatments. This is one of the most common, probably the most common surgery I do, because so many people have herniated discs in their lumbar spine. And so this is basically a lumbar discectomy. And this is the way that I do it. I do it through a minimally invasive approach. So the incision in the back, and I hope this isn't too graphic for you, is just very small. I put a tube down through that and I dock it on the bone, and that allows me to push the muscle out of the way without disrupting it too much, and that's what makes it minimally invasive. I can then operate through this tube with a microscope and make just a tiny little hole in the bone so that I can pull that piece of disc out and get it off of the nerve and make your leg feel better. At the end, it's just a tiny little incision. And so that's a quick and very successful way to handle radicular or sciatic style pain with surgery. We can't fix everything like that. And sometimes you have to do something bigger. So sometimes we have to do something that's much more extensive, and that might include even putting hardware into somebody's body, such as these screws in the lumbar spine. There are a variety of different reasons why that might need to happen. And again, what it really comes down to is individualizing a surgical plan for a specific patient. This happens in the neck as well. We do small surgeries where we just take out a little disc and put a very small little plate in with a little plug. but sometimes patients have problems that require a much more extensive surgical answer. For our surgery arm at the spine center, we have multiple spine surgeons, and so this is myself and several of my partners, and we together make up the surgical arm of the spine center at Baptist South Florida. And this is just a video that is a patient of mine that we did surgery on, and she kind of talks about it in her own words, and I think it's nice for people to see.
I was athletic. I played volleyball. I was a jock. I did cheerleading when I was in college. So the back problems were part of my life. The joint problems were part of my life. So I didn't think any of it. The thing that was causing her was numbness and tingling in her hands, as well as weakness of her grip, but it was also causing abnormal reflexes. That can progress to very serious permanent spinal cord injury and all of the things that come along with that, like loss of function, loss of ability to use your hands, loss of ability to use your legs, loss of control even over your bowel and your bladder. So she told me, you need surgery. I guess she answered all of the questions even before I was asking it. Like, I do this a million times. I went to so-and-so school. I did how many hours of practice. She was like, okay, you need to schedule a surgery. I took the disc out from the front until I could peel it off of the spinal cord and the nerves. And then I replaced it with a small plug of cadaver bone and then a short plate that goes over the front of the two bones. Everybody took such great care of me that I was, whatever doubts that I had, they dissipated very, very, very quickly. From the moment that I woke up, the pain in my neck was gone. This doesn't fall asleep anymore. It doesn't. It doesn't. Whatever she did, it worked. Now my horizon, like my future, is the way that it should be. I'm going to be able to play volleyball again. I'm going to be able to go to the beach again. I'm going to be able to carry my son again. I'm going to be able to go to his little field day, I don't know, and do the three-legged race. That's what I want. Priscilliana was a joy as a patient. Not only was she very motivated to take care of her own health and to participate in her treatment, she basically was smiling, positive, and upbeat every time I saw her. There are not a lot of neurosurgeons, and for her to be a woman, I mean, she was brilliant, so eloquent, and so she looked tired. She looked fresh and just ready to rock and roll. I recommend the Miami Neuroscience Institute because they listened and they addressed something that I wasn't even trying to address. And because they listened, they figured out what was wrong with me.
So I just like showing that because it gives an example of what we're trying to do, which is give people their lives back. We want to stop pain and we want to get people back to their regular lives. And if we can do that without surgery, that is great. But sometimes you have to have surgery for it. And that's where myself and my partners come in and try to provide that for the community. So thank you. That's it for me.
Thank you, Dr. Reddy. That was amazing. What a powerful video. And even your presentation overall. As I'm sitting here, I had a little bit of back pain here and there, so trying to knock off everything off that list. But it was very informative. I do have a question for you. I would ask, how do we, even though we would love to see your face, how do we not get there? What can we do in our daily lives and taking care of ourselves to not get to that point?
Sure, that's really an excellent question. I'm going to be honest, I could do a whole hour-long presentation on that, but to make it really short, the best things, one major thing is keep from getting too overweight. I know it is a struggle for everybody, but your back health is way better if you're not dragging around a lot of extra weight on it. Number two, core strengthening exercises. So better than CrossFit, better than marathons, better than anything else is core strengthening exercises to really strengthen the abdomen. And then the other thing is, let's just be realistic as we age, just stay active, stay involved in sports, but maybe at a slightly lower level than we used to do in terms of how rough we are on our bodies.
Those are all excellent. And I'm familiar. My sister-in-law actually had a very similar surgery, and her quality of life has just improved tremendously. And she's fairly young and was challenged with the pain. So I think that you really can change someone's quality of life. So thank you for that. I don't see any questions. I think that there's a connection that we're going to make and send you. Let me look at the questions here. We have a question from Mr. Palomino, and we'll connect you after. I think he would like to reach out to you separately and see if there's any way for you to assist him with his patients or his clients, which is great. Overall, I mean, I think we have a really good audience, and we do appreciate your time. If there's no other questions on the chat, I'm very thankful for everyone joining us today and very thankful for your time and for your insight, and looking forward to many more of these webinars with our partners at Baptist Health, South Florida. So thank you again, everyone, and have a great afternoon.
Thank you, everybody, for coming.
Thank you.